Welcome to a panel discussion on peptic ulcer. We've broken the subject down possibly a little peculiarly, but in the development of this particular program, I thought that these three areas might be the best to talk about. First on gastric ulcer, then for that segment on vagotomy, and then the final segment on hemorrhage. And the individuals who I've selected, I think, are particularly appropriate to discuss these particular problems. Stanley Uher, formerly the chairman of the Division of Surgery of the Cleveland Clinic. Now he claims he's just one of their attending surgeons, but knowing Stanley, we know that he's got his fingers in the clinic activities in totality now, too. H. William Scott, professor of surgery and chairman of the Department of Surgery at Vanderbilt University. And then finally, J. Engelbert Dunphy, professor and chairman, Department of Surgery, University of California, San Francisco.
And in discussing surgery for peptic ulcer, our panel moderator, Lloyd M. Niehus, professor and head of the University of Illinois Abraham Lincoln School of Medicine, together with our three other stellar guests, cover specifics relating to antrectomy for gastric ulcer, truncal or selective vagotomy for duodenal ulcer, and when to operate for hemorrhage. On Audio Digest Surgery, Volume 18, Number 24, our final issue for 1971. Now, Dr. Niehus.
Dr. Uher was selected to talk about gastric ulcer. Dr. Uher.
There are two general reasons for operating on a patient with a gastric ulcer. We're all familiar with the possibility of cancer that has to be considered with every patient who has an ulcer of the stomach proper. The other broad sets of reasons are the same reasons that we operate on patients with a duodenal ulcer, namely if they simply can't be controlled on medical means or have had life-threatening complications. Now, in the old days, and perhaps with some internists and family doctors still, it used to be quite a battle for the surgeon to get hold of a patient with a gastric ulcer, because the reasoning used to be, if the patient has cancer, you're not going to cure him, so there's no reason for operating on him. And if it isn't cancer, then there's no reason for operating on him because it can be handled medically. Well, I've gone through my own patients and analyzed the outlook from the standpoint of what the preoperative diagnosis was. And roughly, there's about almost 3 times as good an end result from the standpoint of 5-year survival if the preoperative diagnosis was not frank cancer, it was just an ulcer with a possibility of cancer, as compared with the preoperative diagnosis of frank cancer. So the answer has to be, to people who still reason that way, that if the ulcer, which might be benign or might be malignant, is actually malignant, the outlook is much better in a statistical way than for the patient who has a frank cancer. Now, it was a surprise to me in going over the late results of patients that I'd operated on for gastric ulcer to find out that they weren't nearly all 100% happy patients. This is the final judgment as to whether an operation has been successful or not. It's very unusual to have a recurrent ulcer or marginal ulcer following surgery for gastric ulcer, but it is not unusual. 11% in this series were more or less permanently unhappy, either as the result of the ulcer or the operation which they had later on for the ulcer. So this is a reason for not going the way some of our distinguished elder surgeons have gone in the past and urged an operation for every single patient with a gastric ulcer. Every single person doesn't need it, and not everybody is going to be happy after the operation, even though they no longer have an ulcer. Now, what is the basis for treating a gastric ulcer medically? And as a surgeon, I look at this as the radical treatment of gastric ulcer, because the conservative treatment is to find out what it is in the operating room. There should be no surgical complications, and it should be benign by all the available criteria. Gastroscopically benign if visible, and this has become increasingly important with the better flexible fiber optic scopes that are now available, and with the better techniques of the physicians who are using them. The physician has to be willing to follow the patient. The patient has to be willing to stay under observation. If you're dealing with a migrant population and there's a possibility of a patient with a gastric ulcer having a malignancy, it's safer to operate on him than to try to treat him if you're not going to get him back again. Then the ulcer heals and stays healed in a maximum of 3 months. That's just a figure out of the hat. Some people say 6 weeks and so on. Well, now, remembering the 10% of people who are not happy following gastric surgery, and this was a long-term follow-up. Some of those patients have been followed over 20 years. There has been a swing toward the conservative operation, that is, conserving the stomach, in operating for people who have a gastric ulcer. What are the situations that are appropriate to conservatism? A thin or malnourished patient, a very high ulcer, sometimes an emergency operation for perforation or hemorrhage, and strangely enough, the giant ulcer, which so often is benign rather than malignant. Again, the ulcer must be benign by radiologic, gastroscopic, and cytologic study. The ulcer must be grossly benign in the operating room, and it should be proved benign pathologically by excising the ulcer, multiple biopsy, or a swab and stat cytology. If all of these things are satisfied, then you can take the chance, leave the patient with the stomach, and there will be fewer people in that unhappy 10%. This is how my own thinking has altered in 2 decades. A vagotomy and pyloroplasty I did none whatsoever in the 10-year period, and I managed to do in 25% of the cases in the 10-year period. Now, this is a situation where you simply must not guess wrong, and I'm knocking on wood. So far, I haven't guessed wrong. You have to be sure of what you're doing. I followed all of these people. There was 1 recurrent ulcer in the group. 2 of them have died of other causes, and the others have done well from a clinical standpoint. The biopsies can be done in a number of ways. The prepyloric ulcer behaves, as far as I'm concerned, just like a duodenal ulcer. But you have to be certain about it, and the easiest way to be certain is to open directly over it, and you can take a swab if you've got good cytologic pathologists, or make a cut into the ulcer edge. Here's a way of using forceps, bronchoscopic forceps or whatnot, to reach a high ulcer through a gastrotomy. An ulcer in this site can be excised. This is actually clumsier and more difficult than doing a gastric resection, but it's better for the patient. It also produces, in some instances, a very peculiar looking stomach after you've done this in the reconstruction, but it still seems to work all right. Then a vagotomy and a pyloroplasty would be added to these procedures. I don't open the stomach if I'm going to do a gastric resection for the ulcer. Then I do a definitive resection, presupposing the ulcer to be malignant.
Well, you certainly hit the high points on that broad subject, Dr. Uher. Dr. Scott, what about this vagotomy pyloroplasty as a treatment for benign gastric ulcer? You like that?
Not very much, Dr. Nehus. We have been very much interested in the extraordinary results that Dr. Jack Farris and Gordon Smith have in their series in Los Angeles. We tried a small series in the Nashville area, which was reported a little over a year ago. Dr. Charlie Graham and John Sawyers and I reported about 40 patients that had vagotomy and pyloroplasty used in treatment of benign gastric ulcer. And the results were generally not nearly as good as the results have been using resection of the antrum for benign gastric ulcer. They were a little bit better in patients who had massive bleeding or perforation from a gastric ulcer than they were in those that were uncomplicated by those problems. But on the whole, we couldn't come anywhere close to duplicating the good results that Farris and Smith have had.
Dr. Dunphy, what do you do on the West Coast?
Well, it depends whether you're in the north or the south. In the south part of the West Coast, why, P&Vs get done, I think, fairly liberally for gastric ulcer. We've used the conservative operation primarily for patients with very high gastric ulcers, particularly those that were bleeding. I think it's a good operation for bleeding in the poor risk patient, but we've not used P&V as the elective operation of choice for across the board intractable gastric ulcer. I think one of the reasons is that we've all had the feeling, and I think it's probably correct, that the patient with a gastric ulcer does pretty well with a gastric resection. I mean, it's an old saying, but I think it's a fact. They don't have as much difficulty after a gastric resection as the patient with duodenal ulcer.
Dr. Uher, I sort of missed what your results were with your V&P series. Were you happy with that?
Yes, but I employ this really quite selectively. It's only been in 1 out of 4 patients. One example is a woman with Crohn's disease who's had about 8 feet of small bowel taken out, weighs 90 pounds, and gets a gastric ulcer, which recurs. And you don't want to take out 3/4 of her stomach to deal with that situation. Also, the juxtapyloric ulcer, where you really don't know whether it's on the duodenal side or the stomach side. I think it's very logical to use a V&P there and look at the ulcer at the same time and get a little piece of it. I think if you've got a chronic burrowing type ulcer at the lesser curvature, which has bled a couple of times and is of a fair size, My mental processes don't permit me to see that healing up as nicely as I would like it to, left in the patient with a V&P. So I do a gastric resection, including the ulcer bed.
Well, there's a question brought up, which I was just about going to ask. I get the sensation that you, three of you, as your basic operation for benign gastric ulcer is antrectomy. And I'm always asked this, or my residents say, well, should I do a vagotomy? And I say something, and I'd like to know what you gentlemen, we'll start with Dr. Dunphy this side. Do you, in this particular problem, add the vagotomy to the antrectomy?
No, I don't.
Why don't you?
Well, over the years, the gastric resection has been a good operation for gastric ulcer. Every time you cut something in a patient, if you don't need to do it, something goes wrong.
Dr. Scott.
I think Dr. Dragstad's wonderful work in this area is the thing that should guide our therapeutic thoughts. His argument is clearly that in patients with gastric ulcer, there is usually documented vagal hypotonia, and that this is a gastrin-induced problem, and that it's treated by removal of the organ that produces the gastrin, namely the antrum. I don't think there's any physiologic indication for the use of a complementary vagotomy, but I hasten to say that several years ago, we had a series of a couple of hundred partial gastrectomies for benign gastric ulcer, and we had 5 patients that got recurrent or marginal ulcer in the group. And empirically, on that basis, we began to do vagotomy, sort of a belt and suspenders type of coverage. And Dr. Dragstad has reviewed those patients. We can't find any coexisting duodenal ulcer diathesis in them. And we have no idea why they got the marginal ulcers, which he's always said that they shouldn't have gotten.
But even on the basis of that experience, you still don't usually use vagotomy with antrectomy.
I don't. My residents tend to do so. They're chickens.
Oh, my. We're getting really confused. Dr. Uher.
Well, I'll do it on occasion. Some patients do have a coexisting duodenal ulcer. They'll have a duodenal ulcer scar.
Yeah, but we're not talking about that. That's a different disease.
Yes, but you're operating, the patient may have a duodenal ulcer scar and an active gastric ulcer.
Right.
Under those circumstances, I would add a vagotomy to the gastric resection if I were doing a gastric resection.
Right. I think we're in agreement that you're treating old duodenal ulcer disease and must do the standard thing.
That's why I still think it's worthwhile having, despite all of its limitations, a gastric analysis.
Excellent.
Lloyd, you know something about this. Why don't you tell us whether you do a vagotomy with your
Well, the
gastric
reason I asked the
resection?
question is that I feel that for pure gastric ulcer, with no duodenal ulcer scars, with normal to low acidity, the discussion that have been given is absolutely right, that you should not add the danger of post-vagotomy esophageal dysphagia, diarrhea, and so forth by doing something that is unnecessary. And in addition to the Dragstad stasis theory, do not forget that the antrectomy in gastric ulcer also removes what I think is sick antral mucosa. The term gastritis might be in effect. So you're doing a double thing. You're getting rid of the gastrin factory, and you're also getting rid of sick mucosa. Well, I think that sort of titillate our interest to come up now with Dr. Scott to talk on the subject of vagotomy.
As all this audience knows, in the last 2 decades, largely due to the superb work of Dr. Lester Dragstad, vagotomy has been firmly established as the fundamental basis for surgical treatment of duodenal ulcer disease. Truncal vagotomy, which was first introduced by Dr. Dragstad in the mid-40s, as you know, is designed to reduce the cephalic phase of gastric acid secretion and to reduce the hypersecretory state that exists in people with duodenal ulcer disease. The fact that this interfered with gastric motility and gastric emptying made it necessary to add an adjuvant drainage procedure. The 2 most popular procedures which have been used in combination with truncal vagotomy are antral resection and pyloroplasty. Antral resection, as you know, is aimed at avoiding the post-vagotomy gastric stasis that exists after a truncal vagotomy by ablation of the antrum and thus eliminating the source of gastrin hyperactivity. And with pyloroplasty, the aim is to produce drainage of the antrum and accomplish the same thing in that way. Truncal vagotomy, when combined with antral resection, applied to 2,150 patients, represents the large series started in Nashville in 1947 by the late Dr. Leonard Edwards and continued by Dr. Harrington, Dr. William Edwards, our group at Vanderbilt, on through the years. And the results in the great majority of these patients have been quite satisfactory. The principal item, of course, has been the extremely low incidence of recurrent ulcer disease, but the mortality rate when this operation has been applied to the various complications of duodenal ulcer disease remains higher than desirable. With truncal vagotomy and pyloroplasty, Dr. Weinberg in his wonderful series from the Long Beach VA Hospital accomplished an incredibly low mortality rate of 0.5%, and what we have to consider today to be an excellent low rate of recurrence of ulcer after vagotomy and pyloroplasty of 4.5%, but still this figure is a great deal too high when compared to the low incidence of recurrence after vagotomy and antrectomy. The late Dr. Henry Harkins had a great deal of criticism of the extra gastric effects of truncal vagotomy, feeling that it interfered with the innervation of the gallbladder, the parasympathetic innervation of the gallbladder and the biliary tract, the pancreas, the small intestine, and a portion of the right colon, and felt that these ill effects could be avoided. In addition to changes in gallbladder function, it is thought that there is impairment of pancreatic exocrine secretion, that there are changes in the intestinal tract which end up by producing a diminished fat absorption with accompanying steatorrhea and episodic diarrhea, and that these extragastric sequelae of complete abdominal vagotomy, Dr. Harkins and others, including our moderator, Dr. Charles Griffith in this country, back some 10 years ago, felt could be avoided by using selective gastric vagotomy. In selective gastric vagotomy, as you know, the vagal trunks are preserved with the anterior trunk's hepatic branch and the posterior trunk's celiac branch, with division of the branches of the vagal trunks which pass to the entire stomach. This hopefully results in denervation of the parietal cells in the antrum of the stomach, but does not interfere with the parasympathetic innervation of the remainder of the gastrointestinal tract. We, Dr. Sawyers, Dr. Edwards, and I, about the time Dr. Harkins presented his data some years ago, were very skeptical about the fact that this would do all the great things that it was supposed to do. We didn't feel that we had all these terrible extragastric sequelae in patients with truncal vagotomy and antrectomy, and so we set up a prospective ongoing series of patients who had duodenal ulcer and patients who are going to have vagotomy in association with a pyloroplasty and repair of a hiatal hernia. And we studied, using a random card pulled at operation, a group of 143 patients over a period of about 5 years, using truncal vagotomy versus selective vagotomy. In most of these patients, antral resection was done as an adjuvant complementary procedure, but a number of them did have pyloroplasty. In general, there was very little difference that we could determine clinically between the two types of vagotomy. I should indicate to you that the series was skewed in the direction of more patients having truncal vagotomy than selective, because of the fact that selective vagotomy is not a desirable procedure, in our opinion, to apply to a terribly obese patient, nor is it a good procedure to use in someone who is being operated on at age 85 for bleeding duodenal ulcer. So that when patients had serious complications of this type, we did not follow the random selection, and this simply indicated to us the clinical applicability and limitations of the selective procedure. In following this study up, 134 patients in the group had good enough evaluation to let us study the incidence of the dumping syndrome as a clinical problem. The majority of both types had no significant dumping symptoms. The others had only mild symptoms in most instances, and only one patient in one group with truncal vagotomy had a severe dumping problem. The same was true with bowel function. Normal bowel function was achieved by 88% of the group with selective vagotomy, a somewhat smaller percentage with the truncal group, and 21% of the group with truncal vagotomy did have episodic diarrhea. 12% in the selective group had that problem. This difference, however, was not statistically significant. The thing that came out of the study that was most impressive to us, in the 96 patients who had Hollander insulin tests for completeness of vagotomy done 6 to 30 months after the operative procedures had been carried out, we found, to our dismay, that in our own hands, with Dr. Sawyers at the Nashville General Hospital doing the operation or supervising our resident there, with Dr. Edwards doing the same thing at St. Thomas Hospital, and with me doing the same thing at the Vanderbilt Hospital, that we got an incidence of almost 20%, 19% positive Hollander tests after doing truncal vagotomy. And in the selective vagotomy group, we only had a single patient who had a positive Hollander insulin test. We had to conclude from this study that the careful anatomic dissection which is needed in doing selective gastric vagotomy provided in our own hands greater accuracy of gastric vagal denervation than did the technique of truncal vagotomy that the same surgical group was using. 4 years ago, we began another randomized study based on this first study. We were criticized in the original study for not using good statistical controls, and it was, I guess, a little bit on the crude side, but I think we learned something about the applicability of selective vagotomy from the study. In the new study, we proposed to use selective gastric vagotomy as treatment for all patients of a carefully selected group of patients who had duodenal ulcer and who were to be submitted to operation on an elective basis, excluding those who were in the emergency group. And in these, we proposed to randomize the two adjuvant procedures that are most popular and seem to be most physiologically appropriate in combination with gastric vagotomy, namely antrectomy with either a B1 or B2 anastomosis, and a pyloroplasty of the Finney or Jabelet type designed to produce the most dependent drainage of the antrum that pyloroplasty can produce. In this group of patients, clinical evaluation was made every 6 months with the follow-up of the Hollander insulin test and the assistance of our gastroenterologist in evaluating the patient's result. There are 79 patients who have been admitted to the study thus far, ages ranging from 16 to 76. We tend to use a Billroth 1 gastroduodenostomy whenever technically and anatomically feasible, and in this group the Finney pyloroplasty was done in the majority of them. Only a few had the Jabelet gastroduodenostomy. Clinical results: there's no operative mortality. In the great majority of cases, the results were equally satisfactory in the two groups. There was a single poor result in a patient who had an antrectomy, and we'll hear more about him later. There was one poor result in a patient with a pyloroplasty, and a fair result only in another patient with a pyloroplasty, but no real difference in the clinical results. As far as dumping was concerned, the same type of findings occurred, no real difference between the two groups. Nobody had severe dumping. As far as diarrhea was concerned, again, no great difference between the two groups. There were a few more people, interestingly enough, in the pyloroplasty group who had mild diarrhea as a problem. No one had severe diarrhea as a problem in either group. The Hollander insulin test was carried out in 66 of the patients in periods of 3 to 30 months after the operations had been carried out. And to our dismay, we found 3 patients who did have positive early rise Hollander tests, which were indicative in our standards of evaluation of incomplete vagotomy. The late rise did occur in 5 patients. This probably means that a vagal fiber, hopefully not of clinical significance, had been missed. But the incidence then of incomplete vagotomy of the serious type in the series was 4.5%. One patient in this group developed a recurrent ulcer. Interestingly enough, he is the only one who did. The other patient who had a positive early rise insulin test has continued to get along quite well with no evidence of recurrence and has a good result. One patient in the pyloroplasty group has gotten along nicely 44 months after the operation. The patient who developed recurrent ulcer is a young man who had an antrectomy with a B1 anastomosis and had a positive Hollander. He was reoperated on 17 months after operation, and Dr. Sawyers found that he had vagal fibers from the posterior trunk entering the stomach. These were divided. His Hollander test has remained negative. It's been checked on 3 occasions since this, and he's continued to get along well, having healed his marginal ulcer. We conclude from this study, even though this is a preliminary study, that there seems to be no significant difference between the adjuvant operation of antrectomy and the adjuvant operation of pyloroplasty in patients when gastric vagotomy is complete. And so the moral, I think, is to do a complete gastric vagotomy, and if this can be done, and if we can learn to do this appropriately, then the clinically safer procedure of pyloroplasty can happily be done with good results, and this changes the previous attitude which we've had about the use of antrectomy as the most desirable adjuvant procedure.
I do hope that you all get the nuance here, which I will repeat as someone who's been interested in this subject for a few years. We've been bragging about vagotomy antrectomy of having a 0.5% recurrence rate, the best operation ever devised in the history of peptic ulcer surgery. But then we say, well, we had a little mortality rate, so maybe you should do V&P. But V&P standard has had a recurrent ulcer rate ranging from 5 to 17, 20%. And you've heard just now about using a more refined way to be sure you have a more complete vagotomy. At least that's why we think we get the good results. Dr. Scott gets the good results of selective vagotomy pyloroplasty, which is giving him so far no recurrence rate, no mortality. And man, I tell you, that might mean something as we go through the years ahead of us.
The conclusion of Dr. Scott's presentation also signals the end of Side A of this program, Doctor. Side B can be heard by just flipping over the cassette or 2 reels on your tape recorder. Side B, Audio Digest Surgery, Volume 18, Number 24, continuing a program on surgery for peptic ulcer. Now, once again, our panel moderator, Lloyd M. Nehus.
One of the things is I could never understand about American surgery, and of course I know that Scott has done selective vagotomy, but let's just, for kicks, find out what the resistance of someone like Stan Herr and Jay Engelbert is about selective vagotomy. Stan, why do you resist this so much?
I'd just like to tackle both you and Bill Scott on this mystery of how you get a more complete vagotomy by doing such a complicated thing, often hidden in fat, where you really can't see, where I can't see what I'm doing, let's say. I don't see how you can get more fibers that way than dealing with the nerves up where you can see them.
Well, let's have Bill Scott answer that.
Go back just a bit in time to the days when you were instructed in bacteriology, Dr. Herr, to do a study, a smear for acid-fast disease. And in this, you could make a diagnosis very quickly if you found an acid-fast bacillus in your microscopic field, and you could make a diagnosis of tuberculosis. But if you didn't, you had to look and look and look and look and look before you could be sure that you had ruled this out. And I think this is the answer. I think that too many people, myself included, when doing a truncal vagotomy, do a very quick job that is lacking in thoroughness. We don't do a good anatomic dissection. And when you do a selective gastric vagotomy, you are like the man who's looking for the tubercle bacillus. You're afraid you're going to miss one, and you've really got to work and do a very careful and precise anatomic dissection of the vagal fibers in order to do the job completely. And I think it's just a matter of surgical anatomic thoroughness. I wouldn't argue with someone who wanted to say, when you got through doing the dissection, if you want to cut the vagal branch to the celiac plexus or the vagal branch to the hepatic plexus, or take out a segment of the trunk when you get all through, I'm not interested in the extra gastric effects very much.
So it really hasn't proven out, has it? It's been primarily in this area of getting the nerves. Dr. Dunphy, after this erudite and brilliant discussion about why it works by Dr. Scott, are you going to be convinced yet?
I'm interested in these nice statistical studies and the fine differences in end results. But actually, in my own experience, the results of operations for duodenal ulcer vary substantially on the basis of the personality of the individual patient. Now, I have a doctor that I've operated on who has an incomplete vagotomy, but he's damn well. If he has a little pain in his stomach, he may sneak in a Rolate or something, but I never see him coming around to complain, and he's been classified as a good result. And I've got plenty of patients with acidity practically, and particularly in our VA population, who have bizarre post-gastrectomy symptoms and other difficulties that are incapacitating. So that I would just say that the individual patient and the population that you're dealing with probably is a bigger component in unsatisfactory results after operations for ulcer than whether you do a selective or a truncal vagotomy.
Dr. Nias, I think it's worth pointing out, first, I think that Dr. Scott showed us there wasn't any clinical difference between a selective and a truncal vagotomy. There's a difference in the Hollander test, and this satisfies the laboratory people, but the patients do just about as well. I think also it's worth pointing out he has categories which I've used through the years: excellent, good, fair, and poor. For all practical purposes, excellent and good can be lumped together. And I think perhaps we ought to do more of that because they're satisfactory results. And the satisfactory results were identical. Now, maybe with the passage of time, there are going to be more recurrent ulcers in the people who have the unsatisfactory Hollander test.
We're going to have my short presentation. Dr. Scott was talking about the selective vagotomy of selecting out those nerves that go to the parietal cells and to the rest of the stomach and save the hepatobiliary trunks and the celiac plexus branch. But at the moment, there's lots of excitement, particularly in Europe and in Great Britain and in Scandinavia, about the so-called highly selective vagotomy or parietal cell vagotomy, a term we prefer. And this all got started, in my mind, by Professor Hawley in Munich, who described beautifully the nerve of Latarjet, which we've known all about through these years but have refused to pay any attention to, namely the nerve to the antrum. And the Hawley concept is, why take it? If you can leave it, keep antral motility, cut the nerves to the parietal cells, do a pyloroplasty, and you have a pretty darn good operation. He's done some 700 of these with low mortality, and it sounds rather good. Well, we decided that we would like to study this in a way, so we did 30 patients and followed them and did some acid studies just to find out what happens when you do this kind of vagotomy. And we did have a follow-up in a few patients, and we certainly don't get achlorhydria. It's a basal secretion, a nice drop post-op, and the stimulated about a 50% drop. Now, is this sufficient to prevent recurrent ulcer? No one knows this at this moment. Possibly we've taken away that drive for hypersecretion during the night or when we get angry at our wives or whatever we get angry at. And maybe it will cure the ulcer. So this is what is being studied around the world today, and I implore all of you not to start doing this because it is a personal concern of mine that it might not be sufficient to prevent recurrent ulceration. Now, the world experience today is primarily in the hands of Johnston and Wilkinson and Leeds, Amdrup well, he was in Copenhagen, now he's in Aarhus, and Professor Grazi is here, I believe he's doing it, and so forth. The reports so far are pretty good, although Wastel of London has done 10 and has had 2 recurrent ulcers, so be careful. The one final point I want to make is this operation has absolutely no advantage over what Dr. Scott just told you about selective vagotomy and pyloroplasty. Unless, in selected cases, you can do the procedure without doing a pyloroplasty. In these patients who have had this procedure, because the pylorus is intact, there's absolutely 000 dumping syndrome. And there would be a great advantage if we didn't have to cut this pylorus. It is a known fact that one of the leading American gastroenterologists, and I kid thee not, he's world-renowned as the leading thinking medical gastroenterologist, says the American surgeons are way behind the times, and why haven't we gone ahead with the PCV, the highly selective vagotomy. And let's just get from these revered gentlemen their view about parietal cell vagotomy with or without pyloroplasty. First, Dr. Uher.
I don't know anything about it. I've had the operation described to me by one of the surgeons in England who's doing it. The whole duodenal ulcer evaluation is very tricky. You don't know what type of people they're operating on. You don't know how long they follow them. You don't know how well they follow them and how much bias goes into the follow-up. I think somebody ought to try it. Maybe Bill Scott will. And maybe it's the operation.
Thank you. Dr. Scott.
The results that we just reported on the selective vagotomy of the old-fashioned type represent preliminary results, and we want to get this series. Then I think we'll have something that we can say. I don't plan to get into the business of parietal cell vagotomy until we've worked this out.
But just
more
philosophically, do you think that there's a chance that if you don't cut the acid production down a little more than my figures showed, they might be in trouble? I mean, what do you think might
Yes,
happen?
I've
Just
read
give me
your
a guess.
paper and know about those 8 patients who had rises in acids after this operation.
Two.
Eight.
Right. Dr. Dunphy.
Just the slightest difference in selection makes a tremendous difference in end results. Is there a medical group that he's working with, and is he operating on only 10 out of 100 patients? And I think until we have that kind of data, we really won't know. The thing that has discouraged me in recent years are the patients that we're seeing who had gastrectomies 20 years ago and had good results from gastrectomy for 15, 18 years and are now coming back with critical nutritional and other problems. There's no good operation for duodenal ulcer, and the best treatment for duodenal ulcer is to avoid operation, if you can do it. If you stick to that and then have the results that Dr. Scott describes, you've got an awfully good operation.
Now, we are going to move right into the problem of hemorrhage. Professor Dunphy has been asked to speak to you. Dr. Dunphy.
The problem that a patient presents to us when he has either vomited blood or passed a copious amount of dark stool and fainted is a continuing one, and in a certain sense at the moment, I think posing even greater problems than a decade ago because of changes in etiology. When presented with such a patient, obviously the question is he going to stop bleeding? Can you go home and have a drink? Have you got to stay by his bedside? Have you got to operate? You recall that it was said if a patient was over a certain age, he should be operated on. If he's under a certain age, 48 or 50, he would probably stop. Used to say if you waited too long to operate, then you had a higher mortality, the effective delay. This was true if you allowed the patient to be in shock. But if he was not bleeding heavily, bleeding intermittently, or he was transfused adequately, the effective delay, in our experience, had no significant alteration on mortality. These are simply little factors to weigh in the balance, and really none of them, in my opinion, are in any sense decisive. In any event, the final decision as to whether you operate or not upon him simply depends upon how fast is he bleeding. And some years ago, Dr. Uher and I suggested that if he bled at a rate of 1 transfusion, roughly every 8 hours, the probability of him stopping was so low that one should operate. And I think that that's still a good criteria, that if in the course of the first 12 to 24 hours, the patient has to be given repeated transfusions because of recurrent syncope, today we would operate very promptly. There are the patients, however, and we're seeing more of them, who come in the hospital with bleeding, usually with hematemesis. After a transfusion, they're improved, but an experienced examiner realizes that they're still bleeding. Their pulse is still up, their blood pressure may be stable, but they're still pulsy, and just common experience indicates to you that that patient is very unlikely to stop. If you are required to give him multiple transfusions from the time of admission, 1 liter, 2 liters of blood, to maintain his circulation, you should operate on him immediately. This is what we would call exsanguinating hemorrhage. And you may have to operate on him without a positive diagnosis. Now, if, on the other hand, he subsides spontaneously, or if the circulation stabilizes comfortably for a matter of hours, then it is possible to carry out the critical diagnostic test. How good is a GI series? I think in good hands it's very worthwhile. And if you have a radiologist who's interested and willing to get up at night and come in and do a GI series, it's worthwhile. But if your radiologist tells you that it's not worth doing, don't bother to call him, because he'll prove it to you when he comes in. Now, newer methods, angiography, we've had a limited experience with, and we are not doing it routinely. Our radiologists prefer, if we call them in, to do a GI series and see what they find, and only resort to angiography in the obscure repetitive bleeder. Now, as you know, the group at Penn have resorted to angiography in a large series of cases and are quite impressed about its value. And I think this again depends entirely upon the radiologist with whom you are working. Again, gastroscopy, esophagoscopy is far more effective today than it was even a few years ago, and we are using it regularly on the patient, even if he is exsanguinating, as a part of his diagnostic procedure, getting him ready for operation, multiple transfusions, doing an esophagoscopy and gastroscopy at the time, primarily to exclude some unusual source of bleeding. A word about therapy. What do you do when you get in? If the patient has a straightforward duodenal ulcer, it's really no problem. If he's under the age of 60, then I think you can do whatever operation Dr. Scott sells to you this year. On the other hand, if he's a poor risk patient, if he's over 60, obese, there's no question in my mind that a vagotomy and suture ligation of the bleeding point is a procedure of choice. On the rare occasions in which one gets in and finds that you're dealing with portal hypertension, despite the fact that every bit of evidence beforehand said this was not the case, we would proceed with an emergent portocaval shunt. The number of these patients in community practice that an individual does are not large. I'm certain that the best way to get out of the tough situation at night is the lesser operation.
Now, the most important area, I believe, in this at the moment is this matter of the stress, the oozing from all over the gastric mucosa. And what is it you do for that particular patient?
Let me say, first of all, that if you think it's a stress ulcer, that is the in-hospital bleeder, patient who's had some other illness, you're faced with a very critical situation. I think we need a tremendous amount of new information on what we're covering in the term stress ulcer, because we also see a patient who's simply taking aspirin and suddenly has a massive, and it can be exsanguinating hemorrhage from an acute gastritis, taking ulcer, maybe a little cortisone for rheumatoid arthritis or something of this sort, and quite a different situation from the patient who has a deep, penetrating post-stress ulcer, as we've seen them, for example, after cardiac operations, a perforating, bleeding duodenal ulcer. So we have to be very specific about what we're going to do. Now, the patient who comes to the operation and has a specific duodenal, either acute, fresh, or reactivated, as a stress ulcer, you don't know it perhaps until you're in there, I think does ideally with a P&V.
With suture ligation.
With suture ligation of the bleeding point. The patient who has diffuse gastritis, we still do P&V on that patient. And some of them, when you do a gastrotomy and look in, there are 3 or 4 little bleeding points. You can put some sutures around them, and I have a feeling that the vagotomy maybe does alter flow through the stomach, shunning it away from the mucosa in some way that it actually is the critical factor in cessation of bleeding in that patient. Now, there is a group of patients that have almost gastromalacia. They almost have an ulceration of their stomach. If you can recognize this straight away, I would do a total gastrectomy. This has not been our experience. We haven't operated on any patients, either in the university, the VA, or the county, in which at the first go-round we recognize this as that kind of a diffuse ulcerative gastritis. And so we have done P&Vs as the primary operation on all of our patients. The last 2 years we've had to reoperate on 2 patients for recurrent bleeding, and both of them had to have total gastrectomies.
Well, this is the series that I mentioned before of the marked decrease in their own group from where they were handling it before, going to BNP and coming down to about 11% in that particular series. You do a wide gastrotomy so you know what's going on in there and clean it out, etc. Dr. Scott, I'd like to hear how you'd approach this, because this is probably one of the key things we should hear today. It's very simple in terms of the known duodenal ulcer, either before or when you get in here, you see it, you do a pyloroplasty suture ligate. But that isn't it. You looked, and now you've got this weeping gastritis. How would you handle that? Maybe you see 4 separate punctate bleeders, but at least 4, and maybe more.
Well, I think, as you know, we talk about stress ulceration as being different, probably in genesis and probably in implication, than ordinary bleeding gastric ulcer or ordinary bleeding duodenal ulcer. And I can only review briefly our own clinical efforts to handle the problem of massive bleeding from stress ulcers. Most of them do have massive bleeding. Most of them, in our experience, have been located in the stomach. They're multiple, usually erosions, and they represent acute ulcers. And the bleeding is usually so severe that in most instances, if it cannot be brought under control by the replacement of blood and the general support of the patient, in a few hours, many of these patients will exsanguinate. We have tried empirically to use empiric gastric resection in the past without vagotomy. We've tried vagotomy and antrectomy, and we have tried vagotomy, gastrotomy, suture of the multiple bleeding points, and a pyloroplasty. And our best results, as far as salvage of life are concerned, have come with the more conservative procedure of vagotomy and pyloroplasty, suture of the multiple bleeding points through a large gastrotomy. The results at best are very poor, however, and certainly are not in the same ballpark with the results of treatment of massive bleeding from an ordinary duodenal ulcer.
Thank you. Dr. Uher.
Well, I looked up a group of about 20 patients that I'd operated on in stress situations. There are 2 types of things. I mean, stress can activate in a previously inactive duodenal ulcer, then the problem is just like dealing with a chronic duodenal ulcer. Our experience, like Dr. Scott, is that the ulcerations are usually in the stomach. If they're in the duodenum, they're also in the stomach. They're superficial. It may be a confluent type of situation where they seem to just be running together. I went at it in a variety of ways. If the ulcerations seem to be in the distal stomach, it seems to me the sensible thing to do is to take out that part of the stomach. If they're very high, I've never yet done a total gastrectomy under these circumstances, but I'm convinced from hearing my peers discuss this that situations exist where a total gastrectomy should be done for a totally weeping stomach. But we've gone at the same line where you see individual bleeders. Sometimes there's just a single dominant bleeding point that you can identify. Ligate it, do a vagotomy and a pyloroplasty, and I've been lucky in connection with the rebleeds. Some of these people die, the results are lousy, but they don't usually die from hemorrhage.
I think that's an important point, because we've had a number of patients that have rebled but did not have to be reoperated upon. When I say we've had the 2 patients that had total gastrectomies had exsanguinating recurrent bleeding. Now, I object to this proposal that all of these patients should be subjected to a total gastrectomy as the procedure of choice, because at least with the patient population that we're fitting into this situation, an emergency total gastrectomy, I'm certain, would have a prohibitive mortality, and as Dan points out, so often they don't ultimately die of recurrent hemorrhage. They die of the complications of the operation and their general poor condition initially.
Okay, thank you. I think we've gotten to feel that it's a matter of judgment about the preoperative situation at the operating table, and there is a tendency toward a more conservative V&P with suture ligation, whether it's in the duodenum or the stomach, always thinking about the necessity, if it's a real diffuse gastritis, to do a high gastrectomy or total gastrectomy. Now, Usually people put in all these questions and nobody answers them, so we're going to ask questions now in rapid fire. Dr. Uher, how much value is angiography in your clinic in massive upper GI bleeding requiring emergency surgery? Do you use it or don't you use it?
We have used it. It has been of help in some cases. We have an enthusiastic radiology team that will appear when the patient is bleeding.
Thank you. I think it's still in an area of people specially interested and isn't available too generally around the United States. Dr. Scott, has there ever been an effort to reanastomose the vagus nerves in a severe refractory post-vagotomy syndrome? That's a good one.
Allah be praised. I'm sure there has not been.
Oh, I'm sure it has been tried by somebody, but I don't think it's worked worth a damn. Dr. Dunphy, what do you do for patients with annoying post-vagotomy diarrhea?
A real severe post-vagotomy diarrhea is a terrible condition, and I don't know what to do for it. You know, you can try anything you want, codeine or so forth, but we have a couple of patients with truncal vagotomies in our VA population that are unable to work because of this symptom complex.
Dr. Uher, are there any operations you know that are good for post-vagotomy diarrhea? The proven?
No.
Dr. Scott?
There does seem to be less problem with severe diarrhea with a selective gastric vagotomy than there is with the truncal. Very few patients need any consideration of an operative procedure, but I think there are a few patients with severe incapacitating diarrhea that may profit by the consideration of a reverse segment. These are few and far between, but a number of them have been helped.
That's more for the dump without the diarrhea, though, isn't it, Bill, that helps? Because I think there is a place for the reversed segment procedure if we're going to get into that. But I didn't know that it helped diarrhea particularly.
Well, I'd advise you not to do it.
So would I. No, there's some work being done, and it isn't been going long enough for us to be able to be authoritative up here about the results. I'm sure you all know that it's being done. What do you do with a patient who has a selective vagotomy, pyloroplasty, and has a recurrent ulcer? Dr. Scott, what would you do?
We would look for evidence of the incompleteness of vagotomy by measuring his acidity and repeating a Hollander test. If he had an incomplete vagotomy with the early rise type of response, one could consider doing a complete vagotomy, but I'm afraid I would be inclined to be a little more practical and less scientific and combine it with a natural resection.
Dr. Uher.
I feel quite strongly about that. I've had tried to temporize with lesser things than gastric resection where there's been a failure of a conservative operation. I think you should go directly to a gastric resection if they get a recurrent ulcer after vagotomy with any drainage procedure.
You have recently written a paper, Dr. Uher, on this subject of the fact that you have one recurrent ulcer and that there's often a sequence then, not just because they have the Zollinger-Ellison, but could you comment a little more about that?
Well, I think that there are probably very severe diatheses that produce a situation very much like the Zollinger-Ellison syndrome due to causes that we're not aware of. And if you do a gastric resection on somebody who's already had a vagotomy and a gastric resection, let's say, my own thinking is that we should go to a total gastrectomy sooner than we do in some of these people, even though you can't prove the ZE syndrome.
A couple more and then we're going to have to quit. How much longer does a selective vagotomy take as compared with truncal, Dr. Scott? Does the morbidity of increased length of time, if it is, or
No,
what is
I
the
think
morbidity?
in a thin patient, it probably takes no more than about 15 minutes, maybe 20. My problem is so often that I'm teaching somebody how to do it, and it can take a little longer when you're using it as a teaching exercise.
We do thank the three panelists and all of you for being here today. Thank you very much.
Thank you, gentlemen, and our thanks, too, to the Board of Regents of the American College of Surgeons for cooperation in recording and disseminating this material. Your next issue, Doctor, will be mailed to you 3 weeks from now, rather than the usual 2, to spread your 24-issue subscription over the 52-week calendar. Audio Digest Surgery is produced and copyrighted by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association.